Hi, welcome to hashtag #CRArthritis. My name is Maya Joshi, and I'm the program coordinator at Arthritis Consumer Experts. I am joined today by Dr. Jonathan Chan, who is leading a session at the CRA meeting on non-radiographic axial spondylitis diagnosis and management. Welcome to our program, Dr. Chan, and thank you so much for joining us today.
Thanks for inviting me.
So we have had the pleasure of having you on our program before, but for any new audience members, can you briefly tell us a bit about yourself and how you are involved in rheumatology?
So I'm a rheumatologist here in Vancouver, B.C. I mostly do clinical practice, but I do participate in some research, particularly in axial SPA and psoriatic arthritis. I did my training here in Vancouver, but then also went to Toronto to learn from some of the best. I don't want to give a hierarchy. I might offend some people. So definitely some of the best out there, and they've kind of given me some of their wisdom over the years. And so right now I participate with SPARCC, which is a Canadian research consortium, and SPARTAN. Participate a little bit with ASAS and GRAPPA and some of the other research groups there.
Right, great. And so in terms of the session that you're going to be presenting at this Friday, can you explain for us what non-radiographic axial spondylitis is and how this differs from other types of arthritis that folks might be more familiar with, like ankylosing spondylitis?
Yeah, so ankylosing spondylitis, it's inflammatory condition that can affect the spine and usually starts in young people. But when it first came, when we started recognizing it, and it's a very old disease. I mean, we have evidence of it in mummies, right? Part of the definition in 1984 was, or the classification criteria, I should say, was X-ray changes, evidence of inflammation seen on X-ray. But X-rays are just casting shadows on a wall, and the quality of the image is pretty poor. And even since that first definition, we've known that a lot of people kind of have that flavor, right? So they took patients who were first-degree relatives of those who had classic ankylosing spondylitis, and a lot of them had the gene or the history, and it sounded like they had stiffness, and it's better with activity, but they didn't have X-ray changes. So, over the years, we've discovered that some patients will evolve towards that classic ankylosing spondylitis with X-ray evidence of sacroiliitis. Other people may not. Or you're catching them early, and we don't want to wait 10 years before someone gets definite evidence on X-ray before we start treating someone or start giving them some prognosis there. So nowadays we are utilizing other imaging tools like MRI, and sometimes people just have a strong clinical suspicion, like they've got the gene, they got uveitis, they got a hot swollen knee, they've got enthesitis, their CRP is elevated. It sounds like a duck and it looks like a duck and it quacks like a duck. So, maybe it indeed is a duck.
Right. Okay. So essentially there isn't evidence on an X-ray, but there's other things which are.
Yeah.
Okay, so then in the case of that form of the disease, non-radiographic axial spondylitis, what are the main challenges related then to diagnosis and or treatment in that disease area?
I think the big challenge is that low back pain, which is the main symptom, is super common. Some studies say 25 to 30% of all people, regardless of the age, have chronic low back pain. And so when you're dealing with just a huge percentage of the population, and it's sometimes hard to distinguish whether it's kind of non-specific back pain or if it is inflammatory. And we often use B27 testing or MRI to help clinch that diagnosis. But it would be impractical to MRI every single person with chronic low back pain, I think, and serially MRI them, right? And so I think especially in certain areas there may not be access to MRI. And so that poses a challenge there. And there is some question as whether or not some of these changes can be transient. And so if you, as I kind of mentioned, you don't want to be MRIing everyone like every 6 months to make sure you capture that condition. So that's some of the challenges that are probably one of the bigger challenges, access to imaging when clinching that diagnosis.
Right. And I have heard that I'm not sure which category of spondyloarthritis this fits into, but I have heard that
Mhm.
there can be up to 10 years difference between when symptoms start and then when a diagnosis is
Yeah,
made.
that's the most. I mean, on average, from when symptoms start to when someone is diagnosed with ankylosing spondylitis or axpa, the average delay is 10 years, and it tends to be longer for females. Females tend to have less uh, X-ray changes, so less of them will eventually get X-ray changes, and so that's why when you look at people who just have X-ray changes, it tends to be more male. But once you factor in MRI and elevated CRPs, and that can be a bit challenging with elevated CRPs just because it's a fairly non-specific test, and so you just have to be cautious about overcalling things with that. But once you had factored those other modalities, then the prevalence in females is a lot higher.
Right, right. And then is there any new information or any way that we can sort of overcome those diagnoses issues?
You know, we've tried to develop kind of a rapid access spa clinic in Vancouver. I had an ACPAC trained physiotherapist who was helping me out. Unfortunately, she went back to the dark side of Ontario. So I'm in the process of still looking for that support. Uh, Thankfully, I have a good connections with a lot of the gastroenterologist, the dermatologist, the ophthalmologist here in Vancouver. And so that is kind of a low-hanging fruit, right? Because in the course of their disease, about 40% of patients will have what we call an extra-articular manifestation, right? So if they have a history of uveitis and low back pain and they're young, I mean, that should be an automatic referral to to a rheumatologist.
Mm.
And in a lot of centers, ophthalmology just doesn't think about that because they're plowing through patients. And so I've spoken to the BC Ophthalmology Association, and thankfully they've been very receptive. And to some degree, they don't have to think about it. They say just send it, John. So that's kind of good for them, and also help to identify patients early.
Right, great. And then I know that you of course haven't done this session yet, but I'm wondering if you can provide us with any highlights or key messages that you will be covering in your upcoming session.
Well, I'm going to talk a bit about imaging. I'm trying not to overemphasize imaging. I mean, Walter Maximovich talks a lot about imaging, and I'll try to um, uh, give some highlights, some broad overview of that, and also other aspects as well. But I think the way that I tell our trainees in Vancouver is that imaging is important and helpful, but it's not the be all and end all. And oftentimes it's not 100%. Like sometimes you do the MRI and it's a slam dunk. Tons of erosions, floor bone marrow edema, and that is helpful. But a lot of the times it's there's a little bit of edema. It's not 100%. You're kind of in this gray zone, and you have to utilize the clinical components to come up with a convincing diagnosis there.
Right. Okay. So you'll be sort of talking about that issue and maybe then explaining those clinical what those.
Yeah, clinical correlation is required. That's what the radiologists often say. So.
Right, great. I mean, it's interesting. I feel like that is something, those issues maybe exist across rheumatic disease areas. Like I know in rheumatoid arthritis, not everybody's inflammation will show up on a blood test, but
Mhm.
then there's still other signs and things.
Totally, yes, yes.
Great. Okay, well then lastly, I'm wondering if there are any lifestyle or self-management tips that you can offer our patients who are living with non-radiographic axial spondylitis or
Mhm.
ankylosing spondylitis.
I mean, we try to encourage all patients with arthritis to remain active. I think there's a big emphasis within AxSpa for core strengthening exercises and just patients with low back pain in general. I think one of the challenges is there's often not access to physiotherapy,
Mm.
and so we have, thankfully, Mary Pack Arthritis Center, they have, if they have a diagnosis of ankylosing spondylitis or AxSpa, they can get free access to physio. But a lot of patients live far out, far in the interior, or maybe they don't have AxSpa, but they still have low back pain. So thankfully, there's a lot of online resources. I found some good YouTube videos, and I just send those out on email to patients. And I say, well, try this for 15 minutes every day. Make it like brushing your teeth. Just do it all the time and give it 3 months. And if it's still really bad, then we can talk about other options. That, in addition to maintaining weight, is another big aspect that you can take control of and have some impact on. Thankfully, there's a lot of general internists here in Vancouver who have extra training in obesity medicine, and so they've been very helpful. I've had a lot of patients have good success with some degree of weight loss. And then, smoking, of course, is just bad for everything. So don't smoke. Yeah.
Right. And sorry to put you on the spot here, but you were just talking about those sort of online resources that are available. Can you think of any just off the top of your head that we could maybe link to?
Yeah, well, right now, actually, with SPARCC, we're piloting a project called We Got Your Back, and it's an educational series in addition to exercise videos. That's not full-fledged yet. I think we're still testing and seeing whether it makes a difference between those who just kind of are given no direction and those who are kind of given this online program. There are a lot of good, so there's a YouTube channels that I just said, physiotherapy exercise for low back pain. And I maybe shouldn't necessarily promote one over the other, but I think a lot of physiotherapists post a lot of good material. It's not necessarily specific to ankylosing spondylitis, but I think a lot of patients with low back pain would likely benefit from some degree of stretching and strengthening.
Right. Great. Well, it sounds like there's some great resources out there, and that what you're also developing with SPARCC will be something that we can look forward to. Dr. Chen,
I'll give the credit to Laura.
okay.
Laura Pressalon. It's her main project. I'm supporting her, so I don't want to take credit for that one.
Okay, great. Well, Dr. Chan, thank you so much for being on our program today.
Perfect. Thanks for inviting me.